Hi, I'm Meg Callahan with Infectious Disease Special Edition, and I'm here at MADID/SIDP 2026. Very exciting new combination meeting this year. And I'm here with Mark Gilchrist, Professor Mark Gilchrist, who just gave a nice talk about OPAT and drug stability. Could you give me maybe a high-level overview about what you spoke about?
Sure, Megan. So we've been working on for the last 10 years or so in association with the British Society for Antimicrobial Chemotherapy, a drug stability scheme which takes older drugs and newer drugs and tries to look at the stability of those in elastomeric infusers to allow people to go home and have the same level of care at home as they would do in the hospital setting.
Okay.
So it's taken about 10 years to get some of the older drugs into, fit for purpose to send home. And that's taken quite a lot of money and effort and logistics to do.
Could you talk me through some of those barriers that would have stopped that beforehand?
Yeah, so a lot of the older drugs have to be given multiple times a day. And because they have to be given multiple times a day, that's tiring for the patients, it's tiring for healthcare and the nursing staff, or a patient has to come back to the facility 3 or 4 times a day. So by designing drugs that can go into elastomeric infusers and they just sit on your hip, they can deliver through a line continuously for 24 hours, means people get their lives back, they can go back and go back to schooling, they can go back to work, and they can get an income, and just makes them feel a bit more normal.
Are there any differences in how that's been given in the UK and the US? Could you talk about that?
It's pretty much, the principle is pretty much the same. So a lot of people think that when you leave hospital on certain regimes of drugs, you have to deliver those in the home setting exactly how you used to. But it doesn't need to be like that. And that's where we talk about antimicrobial stewardship being important, because it allows you to deliver the right drug for the right indication to the right patient. And so a lot of our job in stewardship is making sure we deliver the right drugs in the right settings to patients at home. And then we can use older drugs or newer drugs in a delivery system that is more helpful for the patient. So the difference between the US and the UK are probably negligible. We have the same challenges in how we develop and think about drugs. Patients go to their home no matter where you are in the world. And it's how we enable that to happen.
What would the patient populations you're looking at that would be able to bring it home?
So delivering healthcare in the home very much depends on the disease you're talking about or the infection you're talking about, whether or not we have antimicrobials that are amenable to going home. But OPAT shouldn't be a barrier to the patient population. So we talk a lot about equity of access and equity of care, and more in society we're thinking about that. So if you're at home, we should think about ways in which we can deliver that healthcare in the home. There may need to be additional support, there may need to be additional things we need to do, but in general we try and get the patient home with the best possible package of care. There are some patients we can't do that for, and that's the same no matter where you are. And it's the level of risk, the maturity of the service that you have, and the infrastructure and safeguarding that you have around that service. But I think more and more, there used to be a stage where you would have predefined criteria about who you would take. Mm-hmm. And that exists to an extent, but actually in a more welcoming society, we now look at equity of care and we try and make sure we're having a balanced approach and that our views are not prejudging the ability for somebody to go home.
Other than people wanting to be in their own home instead of being in the hospital, are there any other benefits that have come out in the data about doing OPAT?
Yeah, you certainly got the organizational costs about flow capacity in an organization. You've got the ongoing hotel costs within healthcare. But the quality of life impact models are there. People go home, they eat better, they recover better, they go to school, they can work, they have less associated anxiety. Now that's not published, that's just from what I see with patients coming in to see me. And they they have better family support, they have connections, they can live their life how they normally live their life, other than they've got an infection to deal with. But you find that their general mood increases, their mental health increases, because they're surrounded by the societal things that are normal for them.
Can you walk me through the stability testing for the drugs and how maybe that was different in the UK than it is in the US?
It takes quite a long time to do stability testing for an individual drug. So we're looking at almost 6 to 12 months to get a drug through the system. And by the time we've done the pre-scoping work for the drug, we've worked out how the drug might work in an elastomeric device, and then we take it on to formal stability testing. So we do everything in triplicate, and we have to make sure that the degradation of the drug is okay, the stability of the drug is okay, and we put it through a battery of tests. Now, the approach is probably common globally, but the parameters we use to assess whether or not a drug passes or fails is slightly different depending which country you're in globally. And that's what's caused us to try and come together for a consensus to look at, is there one uniform approach we can take? And that again comes back to equity of access and ability for individual patients in every country to be able to get these therapeutics. So we have the UK, which probably has the strictest criteria. That doesn't mean it's bad, but it's a gold standard for us to reach. But we probably need to come to some sort of harmonization with the rest of the world, so that we have a common approach, so that the older drugs can be used better, the newer drugs can be used better, but they can be used by everyone.
Don't forget to like and subscribe so you can catch everything from Infectious Disease Special Edition.